Yeah. All right. So thank you everybody for today. My name is Damien Zavelas. I'm the nurse unit manager and wound consultant from Hyperbaric Health in Bandura. Today I would like to present you hyperbaric oxygen therapy in diabetic foot ulcers. It's really an update on the evidence, but it's also a call for action. Because this treatment, this adjunctive treatment is part of a multidisciplinary approach, as you're also part of this multidisciplinary approach in diabetic foot ulcers. And if it's used properly in a timely manner, it can save legs, it can reduce major amputation rates, because amputation is directly linked to mortality, it can save really lives. So in Australia at the moment, it's the rates of amputation because of diabetes are really high. It's the second highest rate in the developed world of amputation rates are in Australia. So we really have a call for action to do something better if we can. And one of these things is to use adjunctive treatments like hyperbaric oxygen therapy in a more timely manner and more appropriately. So this presentation will cover four main things. One is the mechanisms of action, for those of you that have never heard about it. So I'll just briefly describe what hyperbaric oxygen therapy does. Then evidence related to diabetic foot ulcers. So we go to the guidelines and the evidence available. Then we go to patient selection criteria with case examples. That will be probably very practical for you, for your practice, to see which patients really you need to think of referring for hyperbaric, and then some treatment logistics and any questions you want to ask at the end. So hyperbaric oxygen therapy, it's not a new treatment modality. It starts from 1960 with randomized clinical trials. And at the moment, there are 14 internationally accepted and approved indications, 7 of which are Medicare covered and funded in Australia. Those are the compression sickness, arterial gas embolism, osteoradionecrosis, necrotizing fasciitis, gas gangrene, diabetic foot ulcers, and soft tissue radiation injuries. So how does it really work? You have to put the patient in an environment of increased atmospheric pressure, and in order to do that, we use hyperbaric chambers. So that's a photo you can see. People sit in this chamber, and we pressurize with air. So the only thing they feel is their ears blocking, so they need to block their ears up to we reach a depth that then we put the mask on. There's always a nurse in the chamber. It's a 2 hours treatment. If anything clinical or technical emergency, the nurse will deal with it and with the patient. So it's a really safe treatment and very easy. Like they sit there, they read the magazine, they breathe their oxygen with a mask. They can just relax or close their eyes. They listen to the radio and they stay there for about 2 hours. And what happened is those 2 hours, I'll show you a very quick video here, just to have a snapshot of the treatment. So basically the patient will come in, enter the chamber, the nurse will assist to sit on the chair, and then we'll try to put together the hood tent or the full face mask. So that's the hood tent, but there's also a full face mask as well. So we're preparing that. Then we start compression. So they need to equalize their ears. So we educate the patient for equalizing techniques like Valsalva maneuver. And we monitor in case there is any issue. We stop the compression so we have it safe in order not to have any barotraumas. Once they go to pressure, they put the hood on or the mask on. They stay there for about 2 hours with the nurse there. So in case they feel anything, they just let the nurse know, and it's pretty safe. So, and then they decompress and they come out of the chamber. So why are we doing all this? What's happening in the chamber during these 2 hours? Many things happen. We'll only focus on the third part that is dealing with wound care and diabetic foot ulcers. It's high arterial PO2. The oxygen elevate in the plasma and in the blood. And by elevating PO2, the arterial PO2, we have enhanced oxygen diffusion to the cellular level. We have restoration of tissue normoxia. We have enhanced phagocytosis, so the macrophages can kill bacteria by having enough oxygen for phagocytosis. We have new angiogenesis. That's something very important for hyperbaric oxygen therapy, and we'll discuss a bit later as well. We have edema reduction and some other mechanisms that we'll talk a bit later. So the most important, one of the most important is oxygen diffusion. So we have direct reverse of hypoxia in the hypoxic tissue while they're in the chamber. And there are studies that they saw that from 1960. So if you go to the chronic wound, you might find arterial or tissue pressure of oxygen about 15 or 20, which is hypoxic, and that can reach up to 660 while they're in the chamber. The other thing that happens, it reduces the local edema of ischemia, not the venous edema, but the edema that is created from the vicious circle of ischemia, edema, and hypoxia. So that local edema is reduced during hyperbaric therapy. And the most important thing that happens is the new capillary formation, as I said before, and you can reach up to 80–90% of the normal tissue capillary volume. And that will actually bring more blood flow and will have a long-term effect. So more blood flow, and then the wound can heal better. And that's actually the most important factor that is predisposing in diabetic foot ulcers, is the microcirculation destruction due to hyperglycemia. So we restore that with new capillary formation. There's also a protective effect on ischemia reperfusion injury. That's more maybe probably for the vascular surgeons. There's also a high antimicrobial effect, either directly with the reactive oxygen species, also by supporting the immune defense, as I said before, with phagocytosis, also indirectly by supporting antimicrobial agents such as antibiotics, beta-lactams, quinolones, or aminoglycosides. They work better under normoxic or hyperoxic conditions. And also it makes more sensitive some anaerobes, like such as pseudomonas, and then they can be killed better easier by antibiotics. And really, when you talk about chronic wounds and diabetic foot ulcers, and you look at the factors that affect healing, most of them will lead to some kind of tissue hypoxia. And we need to understand at what point this treatment will help. Again, another example of the factors, especially for diabetic foot ulcers. So we need to look at all these factors. We need to have a multidisciplinary approach and try to assess all and address as much as we can all of these factors and add hyperbaric oxygen when needed. Going now to the studies that support the use of hyperbaric oxygen therapy, I'll just pick the latest meta-analysis. So one is 2019 from Australia. It says that hyperbaric oxygen therapy improves healing in diabetic-related foot ulcers and reduces the requirement for amputation. But there is a but. The evidence is not very hard, and we'll explain later how we can apply that to our clinical practice in a more safe way. Another meta-analysis that took place this year, February, but that was only for diabetic foot ulcers with peripheral arterial disease. That showed that hyperbaric improved major amputation rates, so it can save legs, it can keep foot in place, but probably doesn't affect much healing. Again, here, the comment is also that patient selection criteria is very important to select the right patient and at the right time. Another meta-analysis from the same group that I discussed before of scientists showed that in non-ischemic wounds, the ones that are just neuropathic and then don't have peripheral arterial disease, probably hyperbaric oxygen therapy doesn't have a place. So keep that also in your mind. Another systematic review, but that's a year before. It talks about refractory osteomyelitis. It's one of the 14 international accepted indications, not Medicare covered as itself, but it fits very well when we treat diabetic foot ulcers and they have bone infection, either alone with antibiotics or in combination with surgical debridement. In all these studies, one of the issues that we have low or moderate evidence is because there are many methodological issues. We go very quickly, but the most important of those are the last two. One is that they didn't have unified criteria for amputation, minor or major, but also they didn't have any test for response to oxygen, and that's transcutaneous oximetry. And we'll talk about that later in this presentation, because that gives up to 75 predictive value. So you will know by doing that test how much the patient will benefit. Of course, with other things on the history, but that's another test to do to predict how much hyperbaric will help. Another thing that will predict the success of the treatment is a study they did, a retrospective study 2 years ago in USA with actually more than 2 million diabetic foot ulcers. And one of the things that is showed is that if the patient managed to finish the prescribed number of treatments, which is about 30, then they have more than 20% success rate than if they're not able to finish the number of treatments prescribed. Because usually patients sometimes will do 10 or 15 because they need to go back for amputation, or they're very sick people. That probably doesn't give the effect that we want to have. So we really aim for more than 20 sessions, because that's where the study showed that there's a maximum plateau of new capillary formation. So after 20 sessions, we think that we have reached all these capillaries that we want to make, and then we give another 10 to 15 sessions just to make sure, or another 20 sessions, sorry, if there's bone involvement. And going to the guidelines now, the Global Vascular Guidelines 2019, they have hyperbaric oxygen therapy included, whereas controversy remains, there might be a role for the use of hyperbaric oxygen therapy in diabetic patients with non-healing neuropathic ulcers of low-grade ischemia, who have failed to respond to conventional wound care. So again, there is some place, but of course it doesn't replace revascularization where possible. And going to the National Working Group of Diabetic Foot, again, hyperbaric oxygen therapy is there on the 2019 update of the guidelines in ischemic diabetic foot ulcers despite best standard of care. So try best standard of care, and then if it doesn't work within a month, hyperbaric should have a place. Again, we need to answer which patients, and we'll do that later on. If you see only the diabetic foot ulcer in terms of infection, hyperbaric can't treat alone infection. You need antibiotics, you need probably surgical debridement. So there's no evidence to show that just hyperbaric can help infection. When we talk about refractory osteomyelitis, yes, there are some evidence. Now going to patient selection criteria, there are two processes. One is to make sure that the patient will be safe to go under hyperbaric and under hyperoxic conditions. So we have a GP doctor who is hyperbaric specialized, and he will go through a full medical history to make sure that there's no contraindication. Really, contraindications are relative. We just need to monitor their lung function, heart function. Sometimes if they have COPD, we need to monitor that. If they have critical issues and they need close monitoring, and they need to do hyperbaric oxygen, then we probably need to speak with the Alfred Hospital in the city. They have a clinical chamber, they have monitoring, they treat ICU patients. So we work together if they need to have closer monitoring. Or they will send us some patients if they are mobile patients at the outpatient setting, and they probably live in our area. So we work together with the Alfred in that perspective. So there are different pathologies that we need to go through. And once we clear them with the doctor, it's very safe for the patient to go in the chamber. Once we do that, then we need to see if that diabetic foot ulcer is right to go to have hyperbaric oxygen. From all the studies that we saw before and we discussed. So there's only one clinical guideline that has been published in 2015, and what it said really is that if there's Wagner 2 or less, so a superficial wound, probably doesn't, hyperbaric, you shouldn't try it. You should continue with wound care alone. But if you have a Wagner 3 or more, so when you have deep tissues involved or bone tissues exposed or tendons, then hyperbaric should be an option if there's no progress within a month. And that month comes from the wound guidelines. There's a 2019 guidelines in wound care saying that a diabetic foot ulcer, it hasn't improved more than 50% within a month, you have to do something else. You have to review your whole dressing plan and wound regime and probably add some adjunctive treatment. And it's really important for diabetic foot ulcer the time, because they are high risk. That's why you send them to, or they come back to you from a high risk foot clinic, because at any point they are still non-healed, they can deteriorate, they can have infection, they can just get worse. So time is really important. In that 1 month window, we just need to have it in our mind. Going further to how the predictive value and which patients are most candidate, we use transcutaneous oximetry. And why we're going to use it? Because, for example, if you have 100% occlusion of an artery, there's no diffusion of oxygen within the plasma to the peri-wound area or to the wound bed. So there's no point of doing hyperbaric oxygen. So if you have this transcutaneous oximetry, measuring oxygen under the skin of the peri-wound tissue, and so, for example, a measurement of below 40 oxygen, that means that they start becoming more hypoxic. Below 20 is really hypoxic. But if you give them to breathe oxygen with a mask, 100% oxygen, and you see that number, that value of 20 or 30 hypoxic wound goes to 50 or 60, that means oxygen response. And that's a good predictive value to try the patient to do hyperbaric, because you can diffuse oxygen to the peri-wound area and you can have new capillary formation at the wound bed or at the peri-wound tissue. So that's very quickly with the transcutaneous oximetry. And the predictive value, it's a big retrospective studies, they talk about that. And there's also a published consensus statement about the values, the measurements, how much should be on the transcutaneous oximetry. And then going to the case study, so you have an idea of what patients would treat, and the outcomes, or what probably you should have in your mind. We really work a lot with high-risk foot clinics, so Northern Hospital, Western Health, Eastern Health, Austin Health, not that much recently, Monash Health. So the centers a lot of diabetic foot ulcers that they are before major amputation. And that's one good example. So they did a very deep bone debridement and very arterial ulcers that are really hard to heal and have new granulating tissue. And with hyperbaric, they have a good healing. Another case, the only thing offered in most of the cases is major amputation. So they just say, try hyperbaric, if not, come back for a BKA, below knee amputation. And we don't really have that, we don't really want to have that all the time, because really, if you have a bone necrosis, you don't have many chances anyway. Or the infection, if it's spread. We had a patient yesterday with a really extensive osteomyelitis. There wasn't really a wound, but at the metatarsal areas, there was abscess, there was bone infection very extended. So you really can't treat conservatively these cases. So we really try to keep that window of 1 month if you have a diabetic foot ulcer. And especially in your setting, the home nursing, because you have patients from the high-risk foot clinic, if you are more alert and say, look, there's a deterioration or it doesn't progress within a month, start thinking of maybe something else. Maybe send them back to the high-risk foot clinic, or send us for a referral and send you back the outcome of the assessment. So that patient didn't lose his foot and he's slowly progressing. Another patient post-surgery, again, post-amputation, he had a wound dehiscence and he had bone exposed. Luckily, he started hyperbaric, foot in place. Another case offered major amputation, again, with bones exposed, osteomyelitis, foot in place. But though the high risk of these patients, he developed on the lateral side, because of poor offloading, another ulcer that ended up being about 3 centimeters deep within 3 weeks. And again, he went back to the high-risk foot clinic, and they couldn't offer anything more than major amputation. So really, your care at the home setting, if you are alert, you can save that foot. So he had Bolton Clarke, I think, and straight away he came back to us with that wound, and we started hyperbaric again, and food stayed in place. Another case, yeah, you probably are you face this type of wounds. This patient had VAC, and probably you have patients with VAC at home. The diabetic foot ulcer, high risk food with peripheral arterial disease, VAC in place more than 2 weeks. VAC dressing needs to be reassessed at least every 2 weeks, and if there's so much slough and necrotic tissue, probably doesn't do good. And here there was also bone exposed. So immediately when they send them to us, we stopped the VAC dressing, we started hyperbaric. There was new granulating tissue formulating after 2 weeks. And luckily with some minor bone debridement, the foot stayed in place. Now, some other leg ulcers, but with diabetes that you probably also face in the home setting, that's a vasculitic ulcer. So there is vein insufficiency as well, but there's also vasculitis like atrophy blans, really hard to heal wounds. Really here, compression is really important, but also if you add hyperbaric at the point that there is infection, you have really good effect. So that was already, falling apart. So it grew up a little bit more and then started healing and then almost still continuing with the Bolton Clarke. Another wound again coming from home nursing. I think that was again Bolton Clarke. That was, I think, more than 8 months, and the patient has that for years, healing and opening again. Diabetes as well. Compression is also very important here in infection control, but in combination with hyperbaric, we have very quick results in 2 months. It also, the time is really important because these wounds can heal faster, even if they don't heal completely. They are the point that they can continue with wound care at home, and they can just heal slowly at home. So that's really important with infection control. Other wounds that they don't heal with a lot of pain, infected on the leg area, again with hyperbaric, this wound only needed 20 sessions, and then they carried on with wound care at home. There was new granulating tissue, infection control management very quickly, so all healed. The same here, more than 4 months at home, came to hyperbaric, healed in 20 sessions, almost healed, and then carried on with wound care. Here I want to show you, sometimes when we do the transcutaneous oximetry, there's negative response, but the American Society suggests that you can try hyperbaric. It's a case-by-case discussion, and if you see clinical response within 5 to 10 sessions, then you can carry on to 30 or 50. So that's an example I can show you after 7 sessions, what means clinical response. That patient didn't have a positive transcutaneous oximetry test, but had positive clinical response after 7 sessions with granulating tissue, so we carried on. Another mixed venous arterial ulcer, many months not healed. The patient here was living far away, more than 100 km away from Bandura, but he could come here and stay. There's free accommodation for these people 10 minutes away from the unit. So they do the sessions and then they go back home. Another radiotherapy injury. So this patient had radiotherapy. So these are really hard to heal wounds. And hyperbaric is indicated and Medicare covered for radiotherapy injuries as well, because of the pathophysiology, which is mainly endarteritis. So going to treatment logistics, excuse me, you send a referral and we contact the patient for an appointment. We have a medical assessment and patient consent. It's usually 30 to 50 sessions, Monday to Friday, 2 hours. There's transport arrangements. So if they're ambulance Victoria, or if they're not, $40 annual fee, we help them to register. They can pick them up from home and they bring them to the unit and then back home, no cost. Accommodation is arranged, as I said before, no cost again. They can come with a relative as long as the treatment lasts. There's no waiting list. Now with the coronavirus, there might be a little bit because we have more restrictions, but in general, there's not. Everything is Medicare covered, approved and funded. There's no out-of-pocket cost fee, even for dressing, so the patients pay nothing. There's routine follow-up with the specialist or with the nurse practitioner or wound nurse if needed, or the podiatrist. We arrange with VAC dressing, so they can come with the VAC therapy. We close it for these 2 hours and we put it back on. So there's a 2-hour maximum window to close the VAC dressing, and we can use that. But if there's IV infusion 24 hours, in that case, we need to wait probably because the pump cannot go into chamber. We also are alert to escalate care in a timely manner. So that's another thing which is important for this high-risk food. There's no really complications, so very uncommon to have any complications. The most common but rare again is barotrauma, and they might skip 1 or 2 sessions. Patient experience really good. In the beginning, they might feel, you know, really difficult to do 30 or 50 sessions, but really it's like a hub. They come here, they, you know, they socialize, they talk about the problems, or, you know, they come together, and it's really easy for them to do 30 or 50 sessions. There's a referral poster I can send you. It's currently under review, but really what it says, and there's a list of reference for that, but really what it says, you know, peripheral arterial disease and diabetic foot ulcers, if it hasn't healed more than 50% in 4 weeks, if the revascularization is not an option, if we want to do in combination with bone debridement, and also in diabetic foot ulcers that also have venous insufficiency, but we need to make sure that it's compression management already in place. If there's not, in that case, if there's less than 40% improvement in a month, that's again something you need to look at for an adjunctive treatment or for a specialist opinion. And there's also some atypical wounds. I don't have the time now to talk about a bit more. I'll send you all the PowerPoint so you can have a look, and you can send me any questions if you like. And the conclusion really for you is that hyperbaric oxygen therapy is not an alternative to standard care, revascularization, offloading, compression, optimal wound care, infection control. But if it can be used as an adjunct in a timely manner, it can reduce major amputation rate. It can keep feet in place and save lives, and it can also save treatment costs, reduce a lot of treatment costs. And that's it. Thank you very much. These are also my details. So if you want to send me any information, any question, you can email me or call me, or through your wound consultant from Bolton Clarke. You can make any questions, and I'm really happy to answer to you anytime. And if you want now all of you to unmute, if you have any questions, I think we have another 2-3 minutes, and then Zoom will drop, unfortunately. So any questions, any of you? Yeah, I will unmute you all, just a minute.